Hi, welcome to our Genetic and the Heart virtual symposium organized by Curie Genetics / John Cha, with tremendous support from Parkway Lab Services, Florence, and an unrestricted grant from AstraZeneca as well. We have an ensemble cast of speakers today, and we'll be talking about the pharmacogenetics and, in particular, its role in antithrombotic use. My name is Dr. Ong Hian Yi. I'm a cardiologist at Mount Novena. I'm a current president of Cardiac Society. Our first speaker is Professor Doreen Tan. I knew her as in my past life in restructure as the head of Department of Pharmacy at Khoo Teck Puat Hospital. She's now Associate Professor Doreen Tan at NUS Department of Pharmacy. She's well versed in and has published extensively in pharmacogenetics and antithrombotic. Doreen, you want to take it from here?
Thank you.
You introduce your own title.
Oh, I don't need to introduce lah. I'll just jump right in. I think I thank you, Kay, for the kind introduction. Please go ahead and call me Doreen from here. I'm not here to profess that I know everything about precision medicine or CYP2C19, but essentially I hope that by the end of whatever I'm going to share today, that people are convinced that we shouldn't just be looking to randomized controlled trials or just guidelines to make our clinical decisions. It's critically important to think about patients as a whole. And it's also important to think about pharmacogenomics not as a standalone, but as part of a decision making, the whole continuum of precision medicine and individualization of therapies. So what's the agenda today? Well, I will share with you why the knowledge of CYP2C19 status is important. You might be thinking to yourself, good Lord, I'm seeing stars. I'll explain to you what the star terminology means, how to use this information, and what really is our local context. We will then explore the evidence and also on the background of the cardiology guidelines, how do we then steer this? And then hopefully conclude with something that people can accept after today. So what's the big deal about CYP2C19 and what do we know about it locally? Well, we do know that oral P2Y12 inhibitors that are available to men's use are clopidogrel, prasugrel, and ticagrelor. In Singapore, prasugrel is no longer available, so I'll just restrict our discussion to clopidogrel and ticagrelor. And the main difference between clopidogrel and ticagrelor is that clopidogrel actually exists as a prodrug and requires the body's activation to become an active metabolite, whereas ticagrelor is active as a parent drug. And therefore, CYP2C19 as an issue does not impact ticagrelor as much as it does with clopidogrel. So give you a little bit more information about how CYP2C19 affects the ticagrelor activation in the body. So because clopidogrel actually goes through a two-step activation in the active metabolite before it can act on the P2Y12 receptor site. So if you see this star information, you see star 1, star 2, star 3, sometimes star 5, and star 17. What really means is star 1 is a wild type population of people. Means like you and I who don't have a mutation, then we're considered star 1 or wild type. And if you had a star 2 or star 3, you are considered a loss of function individual. And the loss of function individuals have been associated with a higher risk of adverse cardiovascular events following PCI or stent insertion. Now, if you have a star 17, it means that you're a gain of function. So because we always inherit a pair of alleles, one from our father, one from our mother, they'll always come up in a combination. So this combination of either one or the other will give you a phenotype. And the phenotype is actually how your body responds or how you behave whenever you've got these combinations. So because star 17 is a gain of function, anyone with a star 17 paired with a star 1 or star 17 will be considered ultra metabolizers. Those that are star 1 are extensive or normal metabolizers. And anyone with one loss of function will be considered intermediate metabolizers. And those who are star 2, star 3, star 2, star 3 combinations, they are all considered poor metabolizers. Okay, so hopefully you're no longer seeing stars now. So the people who are IM and PM are considered loss of function. So if you refer to guidelines like the Clinical Pharmacogenomics Implementation Consortium or the CIPIC guidelines, they will recommend that anyone with a loss of function, either IM or PM, should get ticagrelor or prasugrel. So what is the problem? What is the prevalence of CYP2C19 loss of function in the various ethnic groups? You can see here in Japan, China, and the next one, which is a multi-ethnic China population kind of population. You can see that the prevalence of CYP2C19 loss of function is extremely high, sometimes approaching 60%, and in Japan as high as 62%. In the Caucasian population, it's about half of it, 30 to maybe 40%. So what about Singapore, you might ask? And this is based on Singapore data, our own data, Tan Tock Seng as well as KTPH. If you compare the loss of function, which are about 28 to 34% in whites and blacks, in Singapore is as high as a whopping 62%. So this shows that it's highly prevalent in Asians and particularly in Singapore, and surely something needs to be done about this. So further look at phenotypes, and this was a paper that we published, and of course Dr. Ong was on the investigator panel together with Lui Ling, who is not able to join us today. We basically took our patients and we did them retrospectively and looked at the CYP2C19 phenotype. And you can see here that the PMs are at 10-fold increased risk of MACE compared to the EMs, and this is statistically significant. This group is actually not very big, it's about 250 patients. So I suspect that with a larger group, we might be able to see a statistical difference with the IM population. So here you see the Kaplan-Meier curve, and it's very, very clear here that loss of function individuals who are left on clopidogrel have a significantly higher increased risk of major adverse cardiovascular events or MACE with respect to the rest who are either loss of function on prasugrel or non-loss of function. And this was done in the days that we used to have prasugrel still. So the other clinical risk factors are also important, and it shows you that when we control for even the loss of function characteristics, diabetes, PPI use, as well as Malay characteristics are also important. And this underscores the importance of thinking about patients as a whole and not just with the loss of function thinking. So we also simulated cost effectiveness with the loss of function rates in Singapore. And a lot of people will say, oh, since the 62% is so high in Singapore, right, why don't we just use ticagrelor for everybody, right? So that's a natural question that all cardiologists will say. So here we did a simulation and we tested the cost of genotype-guided therapy versus universal ticagrelor, meaning you use ticagrelor for every single ACS patient. And the probability of cost effectiveness with universal ticagrelor is actually only 46%, implying that the genotype-guided therapies are a lot more cost effective than using universal ticagrelor for all our patients following PCI. So fact number one, we always hear people saying randomized controlled trials are, going to be the most important evidence, and international guidelines support the use of ticagrelor or prasugrel over clopidogrel. So then why do we just follow what international guidelines say? Why do we even need to consider CYP2C19 testing at all? So of course, the case for ticagrelor and prasugrel followed the two studies, Plato as well as Triton TME38. And of course, the American and European guidelines will follow through, right? They will of course say, oh, based on evidence, ticagrelor or prasugrel is better than clopidogrel. However, we have seen in literature that these drugs are associated with more bleeding in Asians, be it ticagrelor or prasugrel, either numerically the same or increased, and the context of it being the same was in Prasvit, where in Japanese, prasugrel is used at 1/3 the dosage that we use in Singapore, and that's the Angmo dose, right? The most recent was Tiger Korea, which was a randomized controlled study. And you were able to show that if you used clopidogrel compared to ticagrelor, right, the risk of bleeding is statistically less with respect to using ticagrelor in everyone. Now, note that this particular study was not powered for ischemic endpoints, and so we cannot make any conclusions based on ischemic endpoints for the use of ticagrelor versus clopidogrel. So the Asian guidelines weren't as hot about ticagrelor, of course, because of all the studies that have come forth. And the Koreans should actually be congratulated for writing a risk-based approach in their guidelines. And they actually talk about ischemic and bleeding risk according to risk scores and recommend the use of antiplatelets accordingly with the risk scores that are seen in this table over here. Now, Koreans were able to do this only because they have their own registry studies. They were able to put all this into some sort of a risk stratification. I'm just thinking that local setting wise, we don't have such data. And if we were able to actually access databases and study our own patients, I think we may be able to come up with our own evidence to make our own recommendations as well. So the new guidelines now talk a lot about bleeding risk, right? You've seen precise depth. Precise depth more than 25 is considered high bleeding risk patients. And even more recently, you have seen the HBR or high bleeding risk criteria according to the ARC group. And essentially, what are considered major risk factors on the left-hand side, as long as you meet one, you're considered HBR. Whatever that's on the right-hand side, where minor bleeding risk is concerned, once you have two of them, you're considered HBR as well. So in the new European guidelines for NSTEMI, they have got recommendations according to HBR status as well. So how was this actually derived? Now, this ARC group or the Academic Research Consortium group, right, looked at the high bleeding risk definitions. And as long as anyone met high bleeding risk definitions, they looked at a whole group of people by Tao et al. And they could see that through time, whether it's a primary bleeding endpoint or whether it's periprocedural bleeding in a hospital or post-discharge bleeding, anyone with HBR labeled to them are all at increased risk of bleeding consistently. Now, this is another pictorial showing the number of HBR risk factors. And as you stack up the number of HBR risk factors, you can see that the odds for bleeding or hazard ratios for bleeding increase in a stepwise manner. So what's the big deal now? HBR is also associated with mortality and MI. And you can see that the people who are HBR, right, are also suffering from this double whammy situation where they're also at increased risk of all-cause mortality as well as myocardial infarction. So ladies and gentlemen, isn't bleeding risk important? So what's our local data like? Now, this is an NUH study that was presented in 2018. So this is when ticagrelor and prasugrel was not so much used as yet. And even though on the surface it looks like clopidogrel is associated with more minor and major bleeding, when you actually put that all into a multivariate model, you can see that actually the reason why people bled more was because of CKD, and the impact of the choice of P2Y12 inhibitors actually is no longer important. So it shows that our clinicians are also, maybe because people with CKD, they tend to choose clopidogrel over ticagrelor, leading to this signal that clopidogrel is associated with more bleeding in the NUH cohort. So this is a KDPH prospective cohort where we used a real-world ACS patients post-PCI, and we basically switch therapy according to platelet reactivities. And this is close to 1,000 patients here. You can see that the bleeding rates are extremely high locally. Of course, you will argue maybe it's because of the bruising, which is extremely high in the ticagrelor group, and respiratory as well. But I think the key point that I'm trying to make here is that even though the patients are minor bleeding, right, they can also take themselves off therapy. Patients don't usually ask you for permission before they hold off their medicines. And that could actually be the reason why those at high bleeding risk are also at high myocardial infarction and mortality risk. So all that being said, right, what's the food for thought, right? So ticagrelor may reduce mortality compared to clopidogrel, but the bleeding begets adverse cardiovascular outcomes and death. So then what do we do from here? So maybe the alternate state of things, right, could be genotype-guided selection of antiplatelets because it has shown ischemic and bleeding outcomes that are better than standard care. So what do the ESC 2020 guidelines for the management of NSTEMI say about this? Now, they talk about the escalation, which could be deemed possible for people who are unsuitable for potent platelet inhibition like ticagrelor and prasugrel. Now, they also say that de-escalation may be done unguided based on clinical judgment or guided by platelet reactivity testing or CYP2C19 genotype. So bear in mind that this particular recommendation was made before the onslaught of the publication of Popular and Taylor PCI, for which I think Dr. Edgar Tay will elaborate a bit more later. Just a very quick snapshot of what these two randomized controlled trials were about. Basically, Popular Genetics was about de-escalation from ticagrelor or prasugrel, which are more potent than clopidogrel, to clopidogrel based on a non-loss of function status. And Taylor PCI was based on an escalation strategy from clopidogrel to the more potent agent. So what are the findings? Popular Genetics managed to show a benefit in net adverse cardiovascular events. You can see there, which is a difference of 0.8%. And for Taylor PCI, that was not statistically significant. However, in a subgroup analysis, it appears that the benefit could be within the first 3 months. And this study is likely to be underpowered with respect to showing a statistically different outcome. So I'd just like to point out here that the absolute risk reduction is actually 1.8%. In Plato, the absolute risk reduction was shown to be 1.4%. Now, something that is not statistically significant should not invalidate the findings of a study. In fact, the effect size of a hazard ratio of 0.66 actually confers that there's a 34% benefit or reduction of genotype-guided therapy versus universal therapy for clopidogrel, where we're talking about escalation strategy. So let's not throw that out of the window so fast, because if it's something that we can accept about ticagrelor's benefit, then this is something that we can maybe even consider that genotype-guided therapy is important for our ACS patients. So the other thing I want to point out here is de-escalation has got definitely its benefits. You can see that there's a hazard ratio of 78% or 32% reduction with respect to de-escalation of the more potent agent to clopidogrel. So this evidence pyramid, I shall not belabor the point, but it's just mainly to show you that meta-analysis are important in this whole picture of things. And this is exactly what the Taylor PCI people went ahead to do. They combined several randomized controlled trials to give you this particular meta-analysis. And they were able to show that the people who are CYP2C19 loss of function carriers, when you actually use ticagrelor or prasugrel over clopidogrel, you can actually reduce the relative risk of MESAs statistically significantly. However, when you look at the group that's a non-loss of function carriers, that means if they were non-loss of function, actually when you use clopidogrel or ticagrelor or prasugrel, it really doesn't make a difference. And the p-value for interaction is significant, signifying the importance of CYP2C19 in this whole decision-making milieu. Subsequently, there was another meta-analysis in Lancet, and this particular meta-analysis showed similar things. In fact, it was impressive in that it showed that both ischemic and bleeding outcomes were beneficial when you use genotype-guided therapies. And so this, I think, is good enough evidence for us to consider this for certain groups of our patients. So, fact 3, we live in the real world, not in a cherry-picking clinical trial world, right? So why aren't randomized controlled trial findings always reproducible in the real world? Well, I'll say it's mainly because the clinical trial setting, a lot of times we cherry pick our patients, and the representation of females and Asians are relatively small compared to the rest of the Caucasians in the study. Now, in the real world, only 10 to 30% of those who are offered a randomized controlled trial will take it up. And the RCTs study only one singular intervention. We all know that in the real world, right, it's complicated. It's not like the patients that we see on a day-to-day basis will fit the inclusion-exclusion criteria of what the randomized controlled trial did. So what this means, and this group, Kennedy Martin, did a lit review on representativeness of randomized controlled trial samples and its implication for the external validity. It means about how we would use this evidence in the real world. Now, more than 50% of the time in the cardiology setting, patients that we see on a day-to-day basis will not qualify for randomized controlled trials. And there were several editorials that was written about this. So there were people who say that perhaps we should aggregate information from multiple trials or registries or even electronic health records and large digital data warehouses to look at how our patients fare. And in saying this, I'm hoping to reach out to more like-minded people, right, to form databases of our patients, to look at how our patients perform in the long haul as well. Let's not just be influenced by only what the guidelines say or what randomized controlled trials say. So to further illustrate what I'm trying to say about randomized controlled trial in the real world, so without personalized medicine, and maybe in the real world when we try to recruit patients for randomized controlled trial, maybe we selected the green people because you apply inclusion-exclusion criteria. And so up to 50% of the time, we might already have some answers when we see a patient on the ground. However, this 50% of the time may just give us this information here, but the large majority of the other 50% of the time, right, we cannot make decisions based on randomized controlled trial because the randomized controlled trial will not have answered those questions for us in the other 50%. So with personalized medicine, what I firmly believe in is that we are able to clinically reason that every patient receives the right medicine all the time, or maybe majority of the time, or more than the 50% of the time that we're seeing for randomized controlled trial when we try to apply them just following guidelines or RCTs. So the default practice today for all our ACS patients, we consider ticagrelor as a default, and this is increasingly the trend in the restructured hospitals, I'm sure also in private practice, except when a patient is deemed to be at risk of bleeding. Now, we don't really have a good way of assessing risk of bleeding. And sometimes we know that the impression of a clinician is influenced by the last significant event that they've experienced, right? So we are not always objective in determining who is at high risk of bleeding. Or we sometimes use the ability to afford as another risk factor. So that is hardly ever clinical. And I don't think that's a fair thing to say that when someone cannot afford that we use that to de-escalate the therapy from ticagrelor to clopidogrel. So here I'd like to make the pitch that one shoe that fits a person pinches another, and there's no recipe for anything that suits all cases, right? So following the Galley meta-analysis in Lancet, Sibing and Castrati came up with this schema. And they talked about how maybe the large majority of people who fit what we know about randomized controlled trial, right, where they fit inclusion exclusion criteria, they should be standard of care. However, when you look at things like patient characteristics, maybe high ischemic risk patients or thrombotic risk more than bleeding risk type patients, or maybe in the setting of what we're discussing today, CYP2C19 loss of function, that predisposes our patients to a high thrombotic risk as opposed to maybe bleeding risk. In that setting, we might be able to consider that if they are on clopidogrel, then we may want to escalate them to ticagrelor or prasugrel. Now, the reverse is true if someone is maybe of a high bleeding risk compared to the thrombotic risk, right? And here again, we're talking about genotyping CYP2C19. So if this patient is not a loss of function individual, meaning they are either NM or UM, then what's wrong with giving them clopidogrel? After all, you've seen the evidence that actually when it's a non-loss of function individual, right, means they are extensive or ultra metabolizers, whether you use ticagrelor or clopidogrel, it wouldn't make a difference in their MACE outcomes nor bleeding risk. So let me just pause for a moment and remind everyone about the conundrums in the real world that we really face on a day-to-day basis. Now, how many of you remember the last time when you have that question, whether clopidogrel is good enough for a high bleeding risk patient who is also at high ischemic risk? What about the other person who thinks, oh, this patient's HB is on the low side? Now, should I be using ticagrelor just because he's got an ACS or acute coronary syndrome or a STEMI or NSTEMI when the ischemic risk is low? What about the last group of patients when you think about whether, oh, this guy has dyspnea due to ticagrelor? Should I de-escalate this person since they are low ischemic risk? Now, my question to everyone who is listening today is whether or not we could have an additional risk factor for us to consider to be a bit more sure that we're doing the right things by our patients. So I guess the alternative state that I'm asking everyone to think about is what if you had CYP2C19 information? How would you do differently or what would you do with it, right? So what if you have a very high bleeding risk patient, and this is again the ESC 2020 guidelines, but your patient is also at high ischemic risk? Then are you just going to follow what the guidelines say? Just give them clopidogrel as a monotherapy? What if their loss of function and we know that it's as frequent as 62% locally? What about the people who are low bleeding risk, but also high ischemic risk? Now, low bleeding risk does not mean no bleeding risk, right? Your patients can still get gingivitis or they can get epistaxis, and these are nuisance bleeding that your patients are not going to like at all. And sometimes they take themselves off therapy without telling us, and that's why they get into trouble. So maybe the alternate state of things is to use risk factor stratification, whether it be about bleeding or ischemic risk, right? And potentially risk assessment across the board, whether they're ticagrelor loaded or clopidogrel loaded kind of population. And then if we had the CYP2C19 information, right, we would be able to consider escalation or de-escalation. And now in the light of those high bleeding risk patients, we've seen shortened DAPT durations. Maybe for the people who are at very high risk of bleeding, we may consider shortening their duration of DAPT as well in the long haul. So I'd like to end by saying that life is complicated, but you and I, as heroes of our patients' advocacy and decision making, I think that it's important that we will deal. So I hope that in the sharing today that you have been fairly convinced that we need to do things differently than what the guidelines say. Thank you very much.
Thanks, Doreen. As usual, a massive tour de force of antithrombotic and pharmacogenetics. To summarize what she said, there's loss of function of the clopidogrel metabolizing pathway is important. It leads to poor metabolizers, which has important clinical effects. There's a high prevalence in Singapore, Asian countries, which is not reflected in published European data. There's no free lunch. With great antithrombotic effect comes great bleeding side effects, especially with strong agents such as ticagrelor. And the evidence that genome-guided therapy for antithrombotic doesn't work is actually not conclusive. We don't know if it doesn't work, and there's some markers which suggest that it does work actually. Is that correct, Doreen? Okay, we move on to our next speaker, Edgar Tay. Edgar Tay was previously the director of structural heart disease at NUH. He's also a skilled interventionist. He's now joined the happy side at Mount Elizabeth Hospitals with Asian Heart Cardiovascular Center. Edgar will talk about should pharmacogenetic testing be routine in revascularized patients. He'll talk about the evidence and real-world data. Edgar, do you want to take it from there?
Yes, thanks, Yenny. Oh, something wrong with the slides. Second. Joa is twitching. I think there's something wrong with the play function or some reason. Can you see my slides?
Yes, I think it's on autoplay, you know. Somehow it's been set to autoplay. So you can do it manually like this, then it won't autoplay.
Yeah, I'll just do it like this.
Yeah.
Okay, so thank you very much, Yenny, and thank you for that nice overview by Doreen. So I just want to give kind of an interventionist perspective. As you know, I'm not an expert definitely at genetics, and I'm just basically an interventionist who deals with patients with bleeding and thrombotic risk, as you mentioned. So this is typically patients that, these are basically data that enter our mind every day when we see a patient, someone with a fistula, very severe coronary disease, and when we put in very, very long stents of two very complex PCIs, we always worry whether we are giving the right antiplatelet for the patient, because this could be a patient that have a very high thrombotic risk. And if you look at what the papers show, these are very complex kind of variables that we have been able to define in research, but in real life, we actually don't remember all these things. We only remember the patient have a kind of good feel of whether they have high bleeding or thrombotic risk. So, but this actually crystallizes what we know at the present moment. At the same time, like Doreen says, we also think about bleeding. So when we treat a high thrombotic risk patients with antiplatelet, we always worry about bleeding. And we can also now quantify it, obviously, scientifically with these risk factors that Doreen had mentioned. So major criteria and minor criteria. But in real life, again, it's really an eyeball test that many of us do on a day-to-day basis. And when we want to fine-tune, we look at these scores. So what does the ACC and ESC tell us? Basically, is this is what we really still follow. Patients who are going for PCI, if they have stable IHD, we typically give them 6 months of DAPT with usually clopidogrel. And then if they have a high bleeding risk, we may de-escalate a little bit. And similarly, if they were on ACS, we usually give the DAPT for 12 months. And sometimes if they're high bleeding risk, we may discontinue at 6 months. So this is generally what most interventionists still use. And we still kind of believe a lot in these very traditional, conventional guidelines. So when I had to do this topic review, I had to kind of first understand from big picture where this CYP2C19 actually stands in the entire field. And so if you look at this picture of thrombotic and bleeding, high bleeding risk or thrombotic risk patients, we know that there are multiple factors that can affect the patient's outcomes. And it's genetics, as you see, actually plays an important part, but it's just one of many, many variables that we as clinicians think about when we treat these patients. So the first study I want to go through is really this seminal work by Mager. This is really the one that piqued the interest of many interventionists, I think in 2009. And this is really a very powerful mechanistic study that shows the first time to the clinicians that if the patient has a loss of functional allele, as you can see, the pharmacokinetic response in terms of the metabolite, active metabolite, is actually significantly reduced in a patient just taking clopidogrel alone. And when they looked at the Triton TIMI 38 patients, this, remember, is a group of patients that was had prasugrel versus clopidogrel. And remember, this is a very high-risk patient. Most of them, all of them were ACS, and in fact, 21% was STEMI. And this group of patients who were taking clopidogrel, those who are carriers of the loss of functional allele had a much worse outcomes, showing that those who have actually a loss of functional allele should be considered differently from those who are non-carriers. So this is the first time we realized that maybe we should think about doing pharmacogenetic testing. And then Mager further concluded with a meta-analysis that shows conclusively in patients that had PCI revascularization from predominantly ACS type situations that actually the presence of this loss of function mutation actually increases the risk of thrombotic outcomes in our patients. So saying that we should really take a look at these patients a little bit more. So there was a lot of interest that year, but then some cold water was poured into the whole field. And this was really the meta-analysis that came about later on that says that maybe genotyping is not that useful for some patients. And this was because the data became more clouded when patients with no PCI were put into the meta-analysis. So really, PCI patients seems to differ a bit from the non-PCI cohort. So as you can see from this cohort and this charisma cohort, actually, if you don't do even if you do genotyping in this cohort of non-PCI patients, there isn't much benefit, as we can see. So it's really the PCI cohort that we need to do testing if we want to consider genotyping at the present moment. And with this set of data, as Doreen had mentioned, the ACC unfortunately had to take a very conservative approach, and therefore they actually do not recommend in 2019 genotyping for escalation and de-escalation. And this is actually just a kind of summary of the data. ESC put in a little bit of a different weak recommendation, which is a 2B recommendation that actually you can consider de-escalation. And this perhaps was because there was some data coming in from the popular PCI study, popular genetic study. So I want to go through a little bit about the two studies that are important for both of us. This is the popular genetic study, which is really people talk a bit as the de-escalation study. So this is really if answering the question, if we do genotyping, can we actually de-escalate some of these patients and not increase the risk of thrombosis? Sorry, still going to autoplay. So remember, this is a group of patients who have STEMI undergoing primary PCI, and all the medications in the initial stage was at the discretion of the center, and these patients were then randomized 1-to-1 after the PCI into standard arm, which means you don't genotype the patient, and then you treat them on prasugrel and ticagrelor for 12 months. This is just our standard conventional arm that we always do as PCI patients come along our way. For the investigational arm, the genetic testing arm, we actually looked at their genetics, and if they were the wild type or natural type where there's no mutation, which is in green, they actually are de-escalated to clopidogrel, whereas those with loss of function allele will still continue on prasugrel and ticagrelor. And we wanted to see whether if we de-escalate this group of patients, whether they had similar outcomes to those that we conventionally treat with the more potent antiplatelet agents. So how does the genetic testing, how was it done? It's really quite simple. They had actually used either the point of care system or a more elaborate serum testing, but they showed that in this trial, this testing could be done really rapidly. So within 4 hours, most of them had the genotype information. And I don't want to bore you too much about the details, but this trial really included patients which are all STEMI, so they're high thrombotic risk patients. They were pretty young, so 62 years old was the median age. And if you look at them, they actually are pretty low bleeding risk cohort. They were young, they had not much previous history of bleeding, and they were only 4% of patients on anticoagulant. So these are actually kind of low bleeding risk patients, but high thrombotic risk patients. So what was the primary outcome? Well, if you look at the primary outcome, which was all-cause death, MI, definite stent thrombosis, stroke, or plato major bleeding, you can see that if you use a genotype-guided therapy, it was non-inferior to the standard conventional arm. In fact, numerically, it looks even better. And what was driving the outcomes was really, I think, the impact of bleeding. So remember, if you de-escalate, obviously you expect that bleeding risk will be better. And so you can see a clear benefit in terms of plato major or minor bleeding if you de-escalate these patients based on the genotyping. And in terms of secondary outcomes, if you dissect it more, it's really the plato minor bleeding that you actually reduce the bleeding. Plato major bleeding, not much different. So really, the impact of de-escalation in this particular study was to reduce the minor bleeding outcomes. When you de-escalate, you also worry, you're going to put the patient at thrombotic outcome. So this is one of the subgroup analysis that you see. And this is really a thrombotic outcome of vascular death, MI, stent thrombosis, and stroke. And you see numerically, it looks pretty good. If you genotype, you don't get a signal of increased thrombotic risk. But you must remember that this is not statistically significant and there's a large confidence interval. So we're not very confident at this point, although the numbers look pretty good, whether we can de-escalate all patients. So the summary is, number one, if you want to genotype the patient, it's pretty easy to do. You can do it quite quickly. It does support a genotyping-based de-escalation strategy. And the main benefit is obviously you can achieve reduction in bleeding rates. And remember, this study is in a pretty low bleeding risk cohort. So if you think about this study, if you were to push it into a high bleeding risk cohort, you're going to probably get even better outcomes here. But unfortunately, this particular study cannot answer the price to pay on ischemic outcomes because it's never powered for individual endpoints of ischemic complications. The next study is a little bit different. The next study talks about escalation. So escalation means that if the patient is on Plavix, do you want to give a more potent antiplatelet based on genotyping? So the research here again is, are we able to use genotyping to try to reduce ischemic risk? And if we identify carriers based on genotyping, can we actually escalate and result in better and less ischemic outcomes? So we go straight into the trial design. So remember, these patients were ACS and stable CAD patients. They came to the cath lab, they had PCI, and then they were screened, consented, and randomized to conventional therapy. So conventional therapy was really clopidogrel plus DAPT with clopidogrel. And in this arm, they had the genotyping done only at the end of 12 months. Why couldn't they do the genotyping earlier on? Because at that point in time, there was a black box warning by FDA. So if they had done a genotype, they were ethically not allowed to then give clopidogrel anymore. So they can only do the genotyping at 12 months. So 12 months later, you will know their status, whether they were carriers or non-carrier. For the genotype group, obviously, we could test their genotype, and then if they were non-carriers, they were given clopidogrel. If they were carriers, obviously they would be escalated. So this is the group of interest. They escalated to ticagrelor. So the question is, at 12 months, if you compare the carriers, loss of function carriers with ticagrelor versus loss of function carriers with the clopidogrel, what was the difference between these two? The endpoint was to look at ischemic complications, so stroke, definite or stent thrombosis, MI, death, and recurrent ischemia, and also looked at the secondary endpoint of major or minor bleeding. Remember, this trial was a little bit complicated, so I'm going to just tell you a little bit about the statistics here. So initially, when the trial was designed, they actually assumed an event rate that was quite high because they thought this was going to be a fairly high thrombotic risk cohort. So they took 12% of an event rate. Remember, in most of the Triton TIMI 38 or the Plato trials, the event rate was pretty high. It was about 11 to 12%. So they tried to use this as the initial event rate, but unfortunately, as they went along, they realized that actually the event rate in this particular trial is very low. So event rates became down to almost about, they had to reassess, and it actually had to be readjusted to 6%. And this actually resulted in a change in the statistics modeling. And at this point in time, they assumed an event rate of 6% in the conventional therapy and 3% in the genotype arm. And this may be actually why you will see that the trial turned out to be statistically negative. So I want to again tell you about this baseline characteristics. Mainly, they are again 62 plus years old. They are quite well mixed, so you can see that there are South Koreans in there, so a significant proportion of Asian patients. And these are patients that 84% of them were ACS patients, so there were a decent number of ACS patients, there were some CAD patients, and there were multi-vessel disease patients. So this is kind of like a group. Initially, I thought they were high thrombotic risk, but if you look at an event rate of 6%, they're at most an intermediate kind of thrombotic risk patients. Again, I think they're pretty low bleeding risk patients in this cohort. So what was the outcome? The outcome was, if you look at the conventional therapy in this orange line and the genotype-guided therapy, the trial basically proved that it was unable to prove that it was not inferior to the conventional arm, even though you can see actually a very large effect size. So you see the blue line actually seems so far apart from the orange line. We think this is actually a very good outcome. And if you look at the confidence interval, actually 0.43 to 1.02 is pretty decent. So you're actually quite confident, right, that most of the patients actually are non-inferior. So actually the genotype-guided therapy actually may work if the number of patients enrolled were larger. And so I think it's a statistical problem with the number of patients enrolled and the planning. So unfortunately, this gave a P of 0.056, but you can see that the confidence interval is actually much in favor of the genotype group. And if you look at the post hoc analysis, which you look at subgroups, if you look at the 90-day outcomes, you can again see that this time the genotype therapy really is effective. And in fact, at this time point, it is actually statistically significant, telling you that perhaps, because we know that when we do PCI, the first 3 months is really the highest thrombotic period. And this is where I think the first 3 months of genotyping actually probably is going to have the biggest benefit. And in terms of safety endpoint, both groups, whether you escalate or not, didn't have an impact on the bleeding outcomes. If you look at the post hoc looking at multiple recurrent events analysis, you again see that genotype guided therapy is actually better than conventional therapy. But this is, remember, the post hoc analysis. So I'll just go right to the end to show you this slide. We've given you some information about de-escalation and escalation, and both seems to be pretty positive in terms of using genotype to guide the patients. And I think earlier on, Doreen also showed you some data of the meta-analysis showing that actually if you de-escalate or escalate, it's actually pretty safe based on what we can see from the large numbers of patients that are pooled together. So I just give you a kind of a what's in the mind of it, at least in my mind, is that whenever you look at a patient, we always look at these two arms, right? Thrombotic risk on the y-axis and bleeding risk on the x-axis. And if you look at patients, for example, in the orange box, so this is a patient with, say, high thrombotic risk and low bleeding risk. Say, typically a patient, say, STEMI, because they're high thrombotic risk, but very young with no comorbidities. So if you think very simplistically, without this concept of genotyping, you would say, okay, let's just give him a potent P2Y12. Doesn't matter anyway because the patient has got such low bleeding risk and high thrombotic risk. We just give him a potent P2Y12 like ticagrelor. And this is a very simplistic view. If you have a stable CAD patient with low thrombotic risk and low bleeding risk, you can just give clopidogrel because either way, it's not going to make much difference. And if the patient has, say, a stable CAD, a low thrombotic risk, but high bleeding risk because they have a gastric ulcer, for example, then just give clopidogrel because you really don't want to escalate antiplatelet here. And of course, in this red box, this is the most difficult. In fact, we deal with this quite a bit. This is the high bleeding risk and the high thrombotic risk patients that sometimes you really don't know what antiplatelet to give. But in real life, unfortunately, the amount of gray boxes are much larger than the amount of kind of orange-green boxes that we have. And really, in clinical medicine, you can't really box them up so easily. And it's really a gradation of risk. And so I would say that if you see a patient with a STEMI, and if the risk of bleeding goes towards the right, meaning you have increasing bleeding risk, then perhaps you want to think about de-escalation. And when you want to de-escalate, probably a good idea is to check the genotype and use some of the data that we presented to you to guide you whether this patient can be de-escalated safely. And obviously the data suggests that if you de-escalate with the genotyping, you will reduce bleeding risk. The question remains unanswered is how much thrombotic risk there will be. But unfortunately, that one will require more further data to come. Similarly, if a patient with stable CAD, say a type A lesion that you're going to stent, and unfortunately, in this particular case, maybe you end up putting more and more stents, and the thrombotic risk gradually increases. Say there was a dissection or something, and you say, okay, this patient, I have to kind of escalate. And again, if you use the Taylor PCI data, escalation may give you some, that set of data may give you some reassurance that you can escalate these patients safely. There are actually also other complexities in the whole field. As you know, you've heard about the impact of this 3-month highest thrombotic risk period. You know, as a patient initially may be high thrombotic risk, but with time, their risk actually can drop. So that again influences your choice. And finally, if you look at this black box right at the lower corner, there's a lot of trials coming our way. In fact, ESC has just published new insights about some of the very short, ultra short DAPT periods of 1 month followed by 11 months of single antiplatelet. And the stop depth actually shows that monotherapy with clopidogrel after a month of DAPD was associated with worse outcomes. This is really making the space very complex. But certainly with the available information, I think there is role for the patients in the gray zones to use genotyping. So thank you very much.
Thanks, Edgar. I think the message is, again, there's no free lunch. With bleeding risk comes, with great thrombotic effect, anti-thrombotic effect comes great bleeding risk. The data for the genome-directed management is very compelling, and it seems to miss the p-value because of low numbers and statistical mathematical reasons, rather than because it's a poor study. And you've shown us how nuanced that the clinical decisions can be for individual patients. We should move on to the case reports. I think maybe what I'll do is maybe after each case report some Q&A, and then if you have any Q&A for the two main didactic talks, then we can perhaps push it to the end of it. We'll start our first case report with Dr. Lim Meng Han. She's a skilled interventionist operating from Mount Elizabeth Hospital, and she's my contemporary, and she was the director of the cath lab in Tan Rong Sing at the time when they started 24/7 primary PCI service. And to say that she treats heart attacks for her breakfast, lunch, and dinner is probably not too far from the truth. Eng Han, are you ready to start?
Yes. All right. Thank you so much, Yanni, for your kind introduction. I'm going to share my slides here. Okay. Are you able to see the slides? Okay, so basically, following on to the previous two speakers, we're discussing something which is more like a paradigm shift in terms of our approach to antiplatelet therapy. In fact, genotype-guided platelet therapy appears to be more and more compulsive as a way to go forward in terms of treating our high-risk patients. So I'm going to share my first case. This is a 61-year-old Chinese male with a long past medical history of coronary disease with multiple stents placed in the left anterior descending artery in 2014. He has background history of hypertension, hyperlipidemia, and diabetes. The diabetes is complicated by retinopathy. He also has long-standing gastritis and is therefore on Plavix instead of aspirin as an antiplatelet agent. But unfortunately, a month ago, before the presentation, he developed iron deficiency anemia with hemoglobin dropping to less than 10, necessitating scoping. OGD and colonoscopy showed that he had gastritis and he had polyps which were removed. But during that time, the patient presented with chest pain and dyspnea and was found to have non-acid elevation MI with elevation of troponin T. Complicating all these, the patient has a background of aspirin allergy, and because it's a high-risk patient, the genotyping for CYP2C19 was sent for testing, and the patient was found to have loss of function allele, and it's an intermediate metabolizer. So this patient, in summary, presents with non-acid elevation MI and has aspirin allergy. On top of that, he is intermediate metabolizer of CYP2C19, which means that he is the 1 in 3 patient that we normally see in our Singaporean context, where patients are intermediate metabolizers of Plavix and therefore partially resistant to Plavix. On the right panel, you can see a short axis and a 4-chamber view showing normal left ventricular ejection fraction. This is an angiogram showing the patent stents in the proximal left anterior descending artery and the distal LAD, but 75% lesion in the mid LAD, which is most likely the one that's causing the ischemia. So this is a patient with an intermediate metabolizer. He has aspirin allergy and has just developed an NSTEMI. What is the treatment strategy for this patient? The patient will have to go for percutaneous coronary intervention, and traditionally will undergo dual antiplatelet therapy for 1 year. And in the case of NSTEMI, usually we would give the patient aspirin and ticagrelor for 1 year, followed by aspirin monotherapy. At this point, we must also take into account that because we have the genetic test for genotype for the patient, then there's a black box warning by FDA for Plavix that patients who are CYP2C19 poor metabolizers may have actually diminished effectiveness of the drug, and compared to the normal CYP2C19 function. So in this case, the drug label suggests that we should offer the patient alternative treatment, and that would be Brilinta. So the patient underwent aspirin desensitization and was given aspirin and Brilinta. So for this case, the role of the CYP2C19 testing is for guiding antiplatelet therapy in a high-risk patient. Is part of the risk profiling of the patient and resulted in a change in treatment strategy. So we have a high-risk patient and a complex PCI. The high bleeding risk is determined using the ARC-HBR consensus statement, which provides us with some consistency in defining high bleeding risk. There is the use of major and minor criteria for the high bleeding risk profile. In this patient, he has anemia, iron deficiency anemia. He actually has evidence of bleeding from the gastritis and the polyps, and he is supposed to undergo planned therapy, planned PCR therapy with 1 year DET therapy. So this is a high bleeding risk patient. We have to weigh the pros and cons of the choice of antiplatelet for this patient, whether there is an argument for de-escalation. Unfortunately, the CYP2C19 test showed that he's an intermediate metabolizer and therefore not suitable for de-escalation therapy using Plavix. This is a patient with high ischemic risk. So presenting with NSTEMI, he has aspirin allergy and a complex lesion. So we have here on two sides, high bleeding risk with high ischemic risk. What is the best therapy for this patient? He started off with Plavix, and in the end, because of high ischemic risk, he was started on aspirin and Brilinta. Okay, these are the pictures. On the right, we see the angiogram of the mid-LED lesion. It's a complex lesion. This is the OCT imaging, which is optical coherence tomography, which is the intravascular imaging within the artery. As we can see the cross-section of the vessel. If we play this, we can see that the presence of previous stents, as shown on these shadows, and significant stenosis in the mid-LED, presence of a lot of calcium, fake calcium. Parts of the calcium is circumferential. This is what we call napkin ring calcium. So this is a high-risk lesion. Oops. Okay. The patient underwent shockwave intravascular lithotripsy because the calcified lesion was not able, we were not able to open the calcified lesion with a plain old balloon angioplasty. With shockwave therapy, the lesion was successfully opened. Shockwave lithotripsy utilizes sonic pressure waves to disrupt the calcium. And during shockwave therapy, electric energy actually initiates the creation of steam bubbles, which expand and collapses and creating sonic pressure waves that preferentially cracks the calcium. So this is the post-stent implantation showing with the OCT picture showing good size of stent. Okay. So I'd like to summarize the first case of today, where we use genotyping to optimize post-procedure antiplatelet therapy. In this, the important thing to note is that Plavix is a prodrug and metabolized by CYP2C19 into active metabolites. The CYP2C19 itself is controlled by loss of function alleles, which, if present, will cause decrease in amounts of active metabolites. And of note, 30% of individuals have loss of function alleles. If you have patients with loss of function alleles, it results in increased platelet aggregation. Increased platelet aggregation it results in increased ischemic outcomes, and there is evidence to show that there is potential reduction of ischemic outcomes if we use genotype guided platelet therapy versus conventional guided platelet therapy in high-risk patients. So that comes to the end of my first case, and I'm happy to take questions.
Any comments, Doreen and Edgar, on this case?
Hi, Edgar, you want to go first or?
You go ahead.
Okay, I thought Dr. Lin Inghan did a very elegant case presentation about this particular case, and I think reinforces the importance that all our patients in the real world, right? A lot of them don't quite fit the clinical trials type of patients that we see. So this is the basic conundrum that we all face. I think Inghan mentioned very clearly that this patient is a high bleeding risk patient. And I think Edgar said it well, that the bleeding risk is also dynamic, right? And this is something that we might have to think about going with time. Well, at this point, we think that we want to give him ticagrelor. We don't know whether he's going to go into trouble later on. It might also be something that we want to dynamically monitor him through time as well. Edgar?
Yeah, I think clearly your case is complex. You have shockwave calcified lesions, very long therapy for stents, and therefore it's clearly a conundrum of the red square right at the top of that chart where you have high bleeding risk and high thrombotic risk. So the most difficult cohort. But genotyping, I think there's some data that shows that carriers may have a slightly a bit more resistant to bleeding as well. So that may have also guided you to be a bit braver when you escalate in some sense. So I think, like I say, there's a lot of this gray, and therefore you can use some of these data to guide you towards to be more confident.
Yeah, I think I just want to add that sometimes the bleeding risk may not be as bad as the ischemic risk, though of course I can be wrong. Acute thrombosis that occurs after stenting has a very high mortality rate, more than 50%. And this is something that we're all extremely scared of. So for me personally, I would actually, now that it is available and it's not very expensive, I would actually send more of my patients for genotyping, because even though it's not in the guidelines yet, we can still utilize it to decide whether we want to, when it's timely to escalate treatment or de-escalate. I think the de-escalation part, hopefully we have more case examples later on that we can talk about.
And then I would like to also remind that there's data that both stent thrombosis and in-stent restenosis are linked to loss of function. So loss of function not only causes stent thrombosis, but in-stent restenosis, which are quite different processes. Okay, we'll move on to our next case. Our next speaker is Dr. Ong Chia Heng, not related. And we get mixed up often when the hospital calls us. So he's an interventional cardiologist. He was previously working for Changi Hospital. He led the acute heart attack program at Changi Hospital, and many of you may not know Changi had the most heart attacks patients per year in the whole of Singapore. Perhaps it's Changi Seafood Village effect, I don't know. And he also trained in structural heart diseases, interventional cardiology. Xiao Heng, you ready to do your case?
Yep.
Show your case? Yep. Go ahead.
Thanks very much. It's a real honor to be here. Thanks to John as well. John Chia, as we all know, is the one who initiated this. And I'm really happy to be able to share a case today with you guys. So it's a very practical case, I think, just to illustrate all the things that has been discussed so far. Yeah, so this is just to illustrate how we use phenotyping or pharmacogenomics in our daily treatment of our patients. So my patient is a 57-year-old Caucasian male. I didn't put that down, but it's a Caucasian. He's got pretty impressive triglyceride levels, which was at 1.10 milligrams per deciliter, and previously not able to bring it down, but currently it's in a very good control with adequate medications. He's got impaired fasting glucose. He was an ex-smoker, but this gentleman actually owns a tobacco business. He's somewhat a tobacco connoisseur, so he tastes tobacco and grades tobacco and tells you whether it's good quality or not. So even though he has stopped cigarette smoking, he is still exposed to tobacco a lot in his daily work. So in 2010, before I first met him, he had an inferior ST elevation MI. He was stented. In 2013, he had another inferior AMI, I presume in the same spot, although I don't have the details, and he was stented again. And then somewhere down the road, he defaulted medication. And in 2018, that was the first time that I met him. Came into the A&E with severe chest pain, and his chest pain is really quite unique in the sense that even after 20 milligrams of morphine, he's still in the same he still feels the same chest pain. But the moment I unblocked his RCA, the pain just disappeared. So he was kind of struggling and squirming all the way till we revascularized him. So he had a mid-RCA occlusion, and I put another stent in. So I presume this is the third layer of stent, although I can't be sure whether it's 2 layers or 3 layers because I don't have the details of the first 2 heart attacks. So I put him on ticagrelor and aspirin because in the Plato trial, we know that for acute coronary syndrome patients, ticagrelor is recommended, at least in most of the guidelines. And I actually extended the ticagrelor for him to 1.5 years. And thereafter, I switched him to, actually, I still left him on dual antiplatelets with aspirin and clopidogrel. And finally, in October 2019, I stopped the clopidogrel and left him on aspirin. He was very compliant, and during this period of time, we've already discussed what happens if he has in-stent restenosis, because this is a layer of stent, and we've already explored the option of bypass in the future. So true enough, in January 2020, he came into the A&E again with the same severe chest pain, and there was absolutely no ECG changes. And I think we can understand that patients who have had recurrent heart attacks in the same territory sometimes don't have ECG changes, but because his pain is so typical, I looked at him, I said, let's go in and do the angiogram. And so true enough, his mid RCA was occluded. This time on the table, we discussed the option of bypass later on. So what I did was I just ballooned it as well as I could, coated it with a drug-eluting balloon, but I did not put in the 4th layer of stent. So I put him on ticagrelor and aspirin, and we decided that after 6 months, we would do another diagnostic angiogram. Before these 6 months came about, he said he felt a little bit breathless. I put him on the treadmill, and the treadmill was abnormal. And true enough, the angiogram about 6 months later already showed severe in-stent restenosis, as you can see below. So as decided before, we've already discussed this multiple times. We've decided that we are not going to stent this again because the same spot is, the same artery keeps blocking up, and therefore he was agreeable to go for bypass. He does have moderate disease in the LAD and the circumflex as well, and therefore he underwent a triple bypass. On the second day of the bypass when he was not on any antiplatelets. I can't remember whether aspirin was started already, but he had another episode of severe chest pain, typical of his previous AMI chest pain, but it resolved after 1 to 2 hours. I think, although we didn't do an angiogram, I think he probably occluded his RCA during that time, but because he had a graft to the RCA, he didn't really have a acute myocardial infarction. So obviously I did his pharmacogenomics, and his CYP2C19 genotype was an intermediate metabolizer of star alleles 1 and 2. And therefore we discussed the choice of long-term antiplatelet. Clopidogrel was not a very good option for him because he's the intermediate metabolizer. Aspirin, he had already had a heart attack while he was taking aspirin. So I offered him a combination of either long-term aspirin plus clopidogrel or a long-term low-dose ticagrelor. And because he is really afraid of another acute coronary syndrome, he decided that he will go on lifelong low-dose ticagrelor. So, so this is just a case to illustrate patients with very high ischemic risk and sometimes the decision-making on what kind of antiplatelets to give to them. And because we have one less speaker today, if I can just squeeze in 1 minute, I just like to say that I also use this test. I know it's absolutely off-label, convince patients to take antiplatelets. Because sometimes we have these patients with, you know, I recently had a patient with osteal LAD, osteal circ 50% narrowing, and he just refused to take antiplatelets. So I said, why don't we do that? Your CYP2C19, and you know, if you're a high ultra metabolizer, then you know we don't put you on clopidogrel. If you're intermediate, then you know it only works half of the time, so you're not going to bleed. You know, or you know, I'm not saying that he won't bleed, but at least it helps him see something visual to help him make a decision on antiplatelets. And if it's a wild type, you know, normal metabolizer, then maybe we can start him on aspirin. So that's another, I think, practical way that sometimes we can use this test to help patients make that decision. Thanks very much.
Okay, thanks, Xiaohing. I think it just shows us how you use genomics to help direct your management. Any comments, Doreen, Edgar?
I think Roger had a question about his LDL control, or whether
Yes.
Xiaohing had information on the LDL.
Okay, I cannot remember right now the exact number, but it's definitely less than 1.8 millimoles per liter. LDL has never been a big issue for him because his triglycerides are so high. Most of the time the LDL is not, you know, we can't calculate the LDL. But right now I can tell you that his triglycerides are well under 1.7 millimoles per liter. I think, if I'm not mistaken, it's less than 1, and his LDL is also under well controlled. So he's on statin, he's on rosuvastatin 20 milligrams, on ezetimibe 10 milligrams, and on lipenopenta.
I think this case is quite straightforward that he should get ticagrelor. So I think Xiaohing didn't need to threaten him too much, right? He was on ticagrelor after the testing.
He doesn't even want to be on dual antiplatelets. I mean, he was very well on dual antiplatelets for a long time on clopidogrel and aspirin.
Yeah.
And he is just an intermediate metabolizer, so but he would much prefer ticagrelor.
Yeah, it would have been an interesting question to think about how long you're going to give him that ticagrelor 60 milligrams BD for.
Yeah, I think although it's off-label again, but we've decided that he's going to take this for life. Initially, he did struggle with breathlessness from ticagrelor. As we all know, ticagrelor increases the adenosine levels, and he did struggle with the breathlessness, but after a while he got used to it, and he's more afraid of his AMI than the breathlessness.
Yeah. I think it's a perfect illustration of shared decision making. Thank you very much for sharing, Xiaohong.
Thank you.
I think this case also illustrates, I think if you, and one day if you decide that you want to de-escalate to something, I think your only choice is I don't know, I think you can't give clopidogrel on this high thrombotic risk patient with the intermediate metabolizer. So I just want to maybe push you a little bit. What would you de-escalate to if, say, after 3 years?
I would seriously consider lifelong aspirin and a combination of both.
Yeah. Sounds good.
Would you consider a low dose anticoagulant and aspirin?
I suppose if you between that and ticagrelor, I think ticagrelor is probably safer. Yeah.
I think that question is hard to answer, right? Because with Roxaban, it was 2.5 milligrams on top of clopidogrel and aspirin,
And
and he
aspirin,
can't
yeah.
do clopidogrel now. So I guess the only recourse is to go with the Pegasus suggestion, which is aspirin and Tica 60 BD.
Okay, thanks. Okay, our next speaker is Peter. Peter, where are you? Can we spotlight Peter?
Hello, hi.
Hi, okay, are you ready? Okay.
Yep, I'm ready.
Peter is a cardiologist. He was previously from Heart Center, National Heart Center, and now he's in private practice with Prime Heart Center. He's an imaging cardiologist, much like myself, with expertise in structural heart, etc. And he's going to present an interesting case, Peter. Are you ready?
Oh yeah, sure. Let me just share the screen first.
I didn't get a sneak preview, so I'm not sure what you'll show us, but
Okay.
surprise us.
Okay, no, mine's actually, I think mine's a very straightforward case. You know, nothing as complicated as the other two speakers so far. But I think I want to share how you know, my thinking process when I was doing the test and how it might help with current decision in terms of dual antiplatelet, as well as subsequent decisions in the future. So this is my case. It's a 66-year-old lady. She had a past history of diabetes, hypertension, and lipids. So all the standard cardiovascular risk factors for about 8 to 10 years on medication, apparently fairly well controlled. She presented with central chest pain, breathlessness, and dizziness for 2 days, worse just prior to admission. No acute changes on the ECG, but the TROP-T was mildly elevated. So this is a case of a acute coronary syndrome, non-STEMI. She continued to have ongoing chest pain while in the ward, so we proceeded with urgent coronary angiogram, and this showed that she didn't have too bad coronary disease, except that she had a very focal tight stenosis of the proximal RCA, about 80 to 90%, which was stented with a DES. Subsequently, she did rather well, and because it was a non-STEMI presentation, she was given ticagrelor, aspirin, ticagrelor, Period. She was on metformin already and some of her existing cardiac medication, but I put her on. I changed her statin to Crestor, and I added on Forxiga for her diabetic control, which was just still mildly elevated. So in her case, there wasn't really too much of difficulty in making the initial decision for using ticagrelor, because she was basically fairly low bleeding risk. But still, I would say she's probably low to moderate. She is 66. She has a history of diabetes, but her hemoglobin was fine. She had no previous bleeding history before. She's no gastric issues before, and no renal sort of impairment as well. So I felt that she was at sufficiently low, maybe low to moderate bleeding risk when making decision on ticagrelor. Subsequently, I also decided to make use of the CYP2C19 test for several reasons. One is because I was really debating in my mind whether I could actually de-escalate her after perhaps even 3 or even 6 months of ticagrelor to clopidogrel, because she wasn't. I didn't feel she was, although she was considered ACS, her trop was only very mildly elevated. Generally, her coronaries look pretty good, and her risk factors are fairly well controlled. So I thought she wasn't at really high risk for, considered really high risk for recurrent thrombosis. So I was actually toying with the idea of de-escalating her a little bit down the line, just to reduce the bleeding risk with ticagrelor, because she is a rather a smaller sized lady. However, the CYP2C19 came back as a poor metabolizer, so so any thoughts of de-escalation, I guess we'll have to continue her with the ticagrelor as long as she can tolerate it for the 12 months. But it's still useful to know, because you know people might still bleed along the way. So I also find it useful to have the CYP2 the test done earlier, in case if she does develop new bleeding in this period of time, then at least I would be able to also make a decision on whether I could use clopidogrel as an alternative. The other situation that I find it will come in useful long term also is quite often these patients have to be on long term single antiplatelet even after the first year, and very often it will be aspirin if they are fairly acceptably low risk of recurrent thrombosis. But quite often I have patients who are also not tolerant of aspirin. They start to develop gastric issues or have a lot of GI related symptoms. So clopidogrel would have been a pretty good choice for long-term use as well. And on top of that, they can also avoid taking additional PPIs, or sometimes so in that case, it was also useful to know whether clopidogrel can be an alternative for long-term single antiplatelet therapy in some of these patients. Yeah, so I think when it comes to short or long-term antiplatelet options, I find this is a useful thing to add because it gives us additional information on top of patients exceeding bleeding risk, thrombotic risk. And I think no matter how even though we should base our decisions a lot on clinical reasoning, but very often patient preference also does come in, especially with longer term use of medication and costs, especially if they need either single or dual antiplatelet for longer than 12 months, then it's also important to be able to make a better decision based on the clopidogrel resistance information. So yeah, that's all I really have to add for this particular case, and how the information has kind of helped me think through how to manage this patient.
And thanks, Peter. Because many of us will step down from ticagrelor after a few months for cost reason. So in this case, you wouldn't step down at all, right?
Yeah, because it's poor metabolizer, so we'll have to continue with that. Unless, of course, she develops bleeding complications, then we'll have to figure out something else.
Yes. Any comments, Doreen, Edgar?
I think it's quite straightforward, this one. Quite clear that the ticagrelor should have been the choice.
Mm-hmm.
Yeah, it's just quite unfortunate. It's a lady plus poor metabolizer. I
These
guess
are
that is, yeah.
super poor metabolizer.
Yeah, 66-year-old. And my guess is that she's Chinese.
Yes, she's.
Yeah.
Yes.
Yeah, because it's most common in Chinese, actually. Loss of function.
Yeah, I think these things really help us make clinical decisions. And if you had stepped down without knowing the genotype, then you could have gotten her. She would have gone into trouble.
Potentially, yeah, that's right.
Yeah, that's right.
I thought it was more reassuring to know when I make such decisions.
Yeah, that's right. Our next case will be from Dr. Chuang. Are you ready, right? Dr. Chuang is previously from National Heart Center. He was my doctor in Cleveland Clinic, and he did his imaging and heart failure fellowship there. He's started Asian Heart and Vascular Center, which is now very successful, and he'll present a clinical case for us to discuss.
Hi, can you hear me?
Yes.
Yes. John, can you share? John has my slides.
Okay.
I think. John, are you around?
Yeah. Sorry. Let me just share the screen.
Yeah. He's on his staycation, so it's kindly.
I think he hasn't checked in yet, though. Hasn't had his tea and scones.
Okay. Yeah, that's good. Okay, so I've been asked, thanks for inviting me to share a case example. I shared an easier case because I think the other case of a rapid metabolizer, I think is a bit too complex in this afternoon, for this afternoon's discussion. This is an 82-year-old gentleman that that was I've been seeing him since 2009 only, when he presented with angina pectoris. He had subsequently done his procedures at Heart Center, where the angiogram was reported as approximate LAD 60%, and he underwent aortic valve replacement with also concomitant Lima to LAD April 2009. In 2011, he presented with acute appendicitis, and in 2012 presented with some anemia and found to have adeno-CA splenic fissure, for which he underwent left hemicolectomy. In 2014, he presented with giddiness and found to have tachybrady type of 6 sinus syndrome with long pauses, and a pacemaker was implanted. Since then, actually, he has been on the Xarelto, NOAC, plus Tembacol, which is flecainide to suppress the AF episodes and keep him out of heart failure. And for the last 6 years, actually, he has been sinus rhythm. He also then subsequently developed intestinal adhesion in 2019, and he has long-standing psoriasis on methotrexate treatment. John, can I ask you to advance the next slide? Yeah, so he then presented in June 2000 with shortness of breath and chest pain, and the echo shows a sudden increase in gradient on his yearly follow-up. There's a sudden increase in gradient transaortic valve with an AVA of 0.7 centimeters square, and this was confirmed on TEE. So this more or less suggests that he has a severe stenosis in his previous bioprosthetic valve. The angiogram shows proximal LAD with 80% with no competitive flow from the Lima, meaning the Lima is actually not supplying the distal LAD actually. And there was also a 90% stenosis in the large ramus. Angioplasty, so we discussed with the patient that he has 2 problems, that of aortic stenosis in a previous bioprosthetic valve and severe coronary artery disease. So after much discussion, we decided to do the angioplasty first, and this was done in June 2020. And then he subsequently 4 months after that, we decided to do the stage TAVI to the severe stenotic bioprosthetic valve. And coming to 1 year, so the question is, what should I step down him to? A few questions I have to answer in this patient. One was, he's an intermediate metabolizer. And so the question is, can I step him down to treatment to a single antiplatelet? Potentially, he also still remains having an increased risk of atrial fibrillation just because we have been suppressing it with very effectively with Tembacol. It doesn't mean that he cannot develop this atrial fibrillation again, and his bleeding risk is actually not low. And in fact, next week I have to handle the issue that because he's so old, next week he has to go for spine surgery. And we had this discussion among the group members, and I must say, as what Doreen has said, there's most of our patients like this with multiple medical problems, usually you don't see them in case series or clinical trials. It's not easy to make a decision whether to step down this patient because obviously he had risk stenosis and he required multiple stenting. And question is whether to escalate the treatment. How about then his risk of atrial fibrillation, his risk of stroke versus his risk of bleeding from his GI problems? So I just throw this to the floor to discuss. Yes, Jenny, go on.
Jenny,
You're
you're
muted. Kenny, you're muted.
Okay. So this is really the antiplatelet is really for the TAVI or for the graft. It sounds like it's for both, right? That's a problem.
Yes, it's for both.
It's tough, a bit evidence-free zone. You'll need something of some sort.
Edgar, do you have anything to say since you're the one who did the TAVI?
I thought yours is the easy case. It became the hardest one. So I think firstly for the TAVI, well, the good news is that the NOACs, we don't usually use it for TAVI nowadays. So they can just be on single antiplatelet actually for the aortic valve. And then for the well, now it's about 1 year post PCI. So I guess we are also in a safe zone because we know that after 3 months, the risk drops significantly. And lastly, I think the patient has atrial fibrillation, although, and the chest is very high. So I think if it was me, I would just give maybe just a NOAC for this patient.
Yeah, I have a question for either Xuan Hong or Edgar. So while you're there, right, did you if you had placed a left atrial appendage closure device, then perhaps he does not have to go for a NOAC. Maybe he can just go for antiplatelets. Would you offer him that?
Yes, and that would have made his chest X-ray a little bit more complex. but it's a good thought because he's very elderly. He's got a very high bleeding risk. He's got cancers and everything. So definitely that remains a possible option. If you had put that in, then he would have a short duration of maybe a NOACs for a month, and then possibly can be transited to a single antiplatelet. In which case, then the choice here would be, I guess, it would be aspirin.
The recent
what does Doreen think?
So,
If
can
you
I
were to
ask,
give one antiplatelet, what would be your choice of antiplatelet? Yeah.
Asking me it. Aspirin. Well, the trouble is that his GI history as well is a very difficult question to answer. Yeah, because even with the twilight population, we didn't have information on high ischemic risk type patients, right? So yeah, it's your guess as good as mine, lah.
and also there's a recent NOAC for TAVI, right? Data from ESC. It wasn't that great.
Yeah, that was the endoxaban data. It didn't show that it was useful.
NOAC for?
NOAC for TAVI.
Oh.
Yeah.
And just to complicate the issue a bit more, so Doreen, this patient is also a methotrexate. I know he has a lot of interaction with the cytochrome pathways as well, right? So I must say that really I don't have much data because of the underlying risk. We thought that although there's not much data in Xarelto on TAVI patients, his AF risk is still, his risk of stroke is still quite high. So we thought that we will give him either a NOAC or still continue with the Brilinta to be safer. I'm not sure what will be your view, Edgar or Doreen.
Yeah, I think the drug interaction issue is another aspect to look into. So that could potentially be a benefit of edoxaban, which we don't have in Singapore. But I do think that drug interaction issue is larger with rivaroxaban than apixaban. I think our difficulty is that we can't measure. That's the problem. So I don't have answers for you either. The question is whether we could also use alternatives to psoriasis. Is psoriasis, right?
Yeah.
Yeah, with methotrexate. Yeah, that one maybe have to work with a dermatologist. Yeah, this is a very difficult conundrum. I was just thinking also that as an 82-year-old gentleman, even if you tried to reason all these things with him, he might not also be able to make a decision together with you. So I think a lot of the decision making will fall on you as a doctor, which is quite harrowing. Yeah.
Yeah, I think
an
it's
enviable position.
Okay, can we?
I think it's a really tough call, but maybe Yanyi, do you want to do a poll, ask questions on whether people want to choose aspirin versus Brilinta? Because my feel is that Brilinta has higher bleeding risk.
We don't have we didn't sell a Google Doc thing or not.
Okay.
I think the global leaders was not unequivocal, so we can't tell which one. But that was a different population, It's not this kind of a difficult patient.
Very difficult.
Yeah.
All right. Thank you.
Thank you. Okay, we're actually sorry to apologize to everyone. We are actually running a bit behind. We should have been finished by now. Our last speaker is actually we kept it to the last so that the way you keep the fastest runner in the hurdles 4x100 to the last. So we've done that. So Roger is a clinician scientist. He's currently the director of the Cardiovascular Translational Research Program. He's the senior investigator and group leader at the Genome Institute of Singapore. I sent all my genetic stuff over to him, and he's going to talk about genetics and genomics for, I think, cardiomyopathy and channelopathies, a bit of different direction. Do you want to take it from here, Roger?
Yeah, thanks, Sinyi. So the discussions preceding this made me realize that it was nearly 2 decades ago since I held a catheter and had to think about antithrombotics. I think this is something like a change of tone. Also, I think people know that John organized this quite a bit for us. So this title comes from him, A Garden Full of Surprises, very cute title that he gave me. And I guess we also know that he's a closet cardiologist as a result of that. Don't know why. But I guess also that the aim is not just the surprises, but maybe a direction into the future for precision cardiology. Then I wanted to put up a slide as a disclaimer to start with very quickly to say that I am a closet molecular and cell biologist because although we are talking here about clinical genetics and the use of genetics and so on, what the lab actually does is go hunting for genes. So for example, we've been looking at the cardiac genome and figuring out how different parts of the genome are actually connected to each other, physical sense. And then in the lab, we've even identified novel genes and been able to give them new names like Singhart and Vanhart, and then creating RNA platforms. So in a way, the clinical genetics research is not my bread and butter. So even that feels like a closet. Okay, so to start at a good ground level, I think is to draw people's attention to how there are 20 to 25,000 genes, coding genes in our human genome. This is not something maybe everybody thinks about every day, but this is definitely what I think about because we use sequencing quite a lot, even in our research realm that you saw in the previous slide. Genes are lined up in series. They can be of varying lengths. As you can see here, some are short and some are long. The key thing is that there are also distances between genes, and some of these can be tens of thousands of bases in between genes. And then altogether, the bases plus the bases between genes and in the genes can really add up to this large number of 3 billion bases altogether. That's the haploid genome. So I guess the key here is to impress to say that the single human genome is vast. And then another form of impression is to say if you have a Bible with this number of characters, then your single human genome is literally 1,000 Bibles. And if when traveling comes back to us and you can go up to London to see the human genome in the encyclopedia form and you flip the book open in Euston Road in this specific museum, you will see really it is an inscrutable code of A, C, Gs and Ts. So each gene confers function to a cell. Many genes participate to produce function. Some genes can be singularly altered, and when they are altered, they can cause mutations. Can cause damage to cell function. But when some genes are actually mutated or altered, they may only change function mildly. So a really good analogy to this is that some genes, when they are mutated, it's like taking a complete pipe out from the organ. But other genes, when they are mutated or have variations, they are really just making the organ play out of tune. So in the realm of genetics, stepping aside from the pharmaco realm that has been discussed all of this afternoon, a way to see it is that in the far end of the spectrum, you have genetics that plays a very strong role because these are monogenic conditions, one gene, one disease, highly penetrant conditions, very famous to our cardiology community. And then on the other end of the spectrum, common conditions that are multifactorial, polygenic. So really, even though the heart may look the same, they are hypertrophic unless you look very closely at them, where there are specific features that tells you it's a flavor of a monogenic condition. It really is quite opposite in the spectrum, although it's beginning to be shown that there are some common genetics that influences how some rare monogenic conditions may be more penetrant than others. So in the big realm of things, if you keep focus on the right side of the spectrum, these are the inherited heart conditions, I would say, that we generally think about in our cardiac field, of course. Muscles, so cardiomyopathy, big vessels, aortopathies, electricals, arrhythmias, and then more recently, pulmonary hypertension and familial hypercholesterolemia. And if people want to look for guidelines, there are several of these around the place. There's clear indications when you should be gene testing your patients and so on. And the reason why gene testing is really worth doing is because the list of genes that we know influence inherited heart conditions are really well known and also very well annotated. And I thought that this paper and the figure here is really nice to show up because we have really gathered so much information to be able to say that there are some conditions where the same gene can cause overlapping conditions, such as these genes on the spectrum here. And then some genes are more likely to cause one condition than another. So I think the understanding for genetics and these rare conditions are really getting much deeper and deeper in recent years. So why could some genes be causing more than one condition? It may well be that the variants or mutations are on different parts of that said gene. Or it could be that different genes are interacting with each other to cause the one condition rather than the other. Or of course, I put this in gray because then there's not so much evidence, more hypothesis that it's a gene environmental interaction that gives rise to these differences. So I guess the reason why people are paying attention to genetics these days is because next generation sequencing has made it super powerful and super accessible. Today, we have a Illumina benchtop that can perform a whole genome sequence in even a week or less than a week at minutiae of the cost that is written here. So as we said, today we can sequence the entire whole genome of an individual, or we can sequence the exome of the individual. So these are your 20,000 coding genes. Or you can sequence a panel of genes. So in our case of inherited heart conditions, we can select the genes that we want to sequence and put them here. Or you can perform a so-called Sanger sequence, which is to look at one single mutational variant, if that's the variant that's running in that family. So because of this very accessible technology, I think this is why we are having these conversations. It's become possible for anyone to get their genes sequenced. It's also really become important to know how to analyze genetic sequences. But more importantly, it's become crucial for careful societies like ours to regulate how people get access to sequencing or who gets access to sequencing. But nonetheless, I think it's widely accepted truth that genetic diagnosis will provide firm molecular diagnosis for patients, give you cascade predictive testing possibilities for families and so on. So a couple of examples. In my case, this is a patient of James Yips in our heart center. It's a patient with well-known Marfan syndrome. And you can see that the genetics really co-segregates with the individuals with their phenotype really well. And what this gives you is the empowerment to offer this testing to their offsprings for predictive testing. And then in another case of a really complex family, just in the interest of time going through really quickly, it's a bus driver whose family tree shows you that there is really something very significantly and monogenic running through it, especially when they're young individuals that are affected. And indeed, the mutation is on a troponin gene that is well known to cause disease too. So these patients have had ICDs put in since then. So there was a recent study that we collaborated with the National Heart Center led by Edmund, who's now become a PhD graduate, so Dr. Edmund Poa. This study collected HOCM patients from both our heart centers. And I think this is a nice study. It's the first that I know of and that I'm involved in, that is showing us that if you take a collection of HOCM patients, depending on how you choose patients to call HOCM, the yield for genetic positive testing is about 40%, which is not far away from what other places in the world count up as well. In other words, 60% of our patients are negative for genetics based on the genetics that we know of what causes HOCMs. And among these patients who are positive, 4 genes are predominating. So these are famous genes in our world of genetics, the MYBPC3, the myosin gene, and then the thin filament gene. And in the study, Edmund was able to pick up 2 new variants in the troponin gene. So these are your thin filament genes that seems to have an enrichment in our HOCM patients compared to control in our Singapore healthy cohorts. And by this measurement, we are calling these now likely pathogenic variants, even though it looks like they may have some relative low penetrance. And if you compare this to what has been found elsewhere, there are also troponin mutations or variants that are found in other populations that looks like they have these sort of low penetrance as well, and also in these two instances too, in 2 different other populations. So just highlighting here that these are the 2 interesting mutations that are found in our population, which we now know we should take careful note of if we do sequence our patients with HOCM here in Singapore. Then I'm flying through a few other slides to highlight the fact that there is sequencing that can be done now to look at your TTR gene for amyloidosis. If this does not bear through, then the mutations, the panels also cover mutations to do with Fabry disease, Danon disease, and of course, these are all rare conditions. Skipping over to familial hypercholesterolemia, I think the crowd here are much more expert about seeing patients with this condition than me. And there are various criteria that people would follow as to who should be gene tested for familial hypercholesterolemia, paying homage to one of these protocols listed as well, which people do know about. And then I fished out a literature that shows us that in a wide population, 1 in 300 individuals may have hypercholesterolemia mutations in their FH genes. And apparently this increases coronary artery disease risk if you look at the prevalence by 18 to 19 times. So it really is something potentially worth testing patients with. And what we then did was to take our SG10K cohort, which is something that I highlighted to Doreen earlier in the chat, to ask the question, how many of these so-called healthy volunteers in the SG10K cohort had pathogenic variants in their inherited cardiac condition genes. So it turns out that surprisingly, there are quite a number of patients, healthy individuals out there with bearing mutations. And maybe not surprisingly, the main disease group is FH, which probably could be a silent condition sitting in the community, which maybe many individuals do not know about. So just skipping along quickly because time is running out, the key genes that we look out for in FH, of course, is LDLR, PCSK9, and hypertriglyceridemia gene, LDL, which also has quite a number sitting in the healthy community. And it's 46 out of the 4,810 individuals that have mutations in these handful of FH genes. 1 in 281 had the mutations in LDLR, which is, as we know, a FH gene as well. And then, as we said, the TG gene is 1 in 171. So the SG10K also gave us the opportunity to see which mutations are frequently recurring. So we found 25 of these variants recurring. One of them in a gene SCN5A, which has to do with Brugada syndrome. And interestingly, this is precisely the mutation that is found in LPL gene, which you say again is to do with TG hypertriglyceridemia, which is actually quite frequent. So found in 15 individuals of this cohort. And then I guess if people wanted to know whether there is ethnic differences, we are finding that some of these are more frequent in one ethnicity versus the other. So there is some detail to when we get this paper to be published to tease that out. And then before we leave this subject, what we were also able to do was to take the SG10K data set and look for patients. As we know, individuals with loss of mutation function in PCSK9, also this other gene NPTL3, if you have loss of function mutation, you could be really protected to against FH, against hypercholesterolemia. So in fact, there is an individual that we found with a protective gene mutation in PCSK9. So you can imagine that if he found another individual like this in the community and they got married, their offspring could really be superheroes with super low levels of LDL. That's just something of interest. So highlighting here two MOH policies that have come up. I don't think these are unfamiliar to the audience. One informing us what levels of gene tests there are, that the way the policymakers see it, and another informing the relationship between gene testing and insurance agencies. So please pull out these to read or discuss them amongst yourself if that's of interest. So we focused on the rare side of diseases so far. John was very keen on wanting to comment about the the common side, which is the left side of the spectrum. And this is where I think if you are familiar with genome-wide association studies, including the kind of pharmacogenetic variants of the CYP genes that you were discussing earlier in previous talks, are part of this polygenic risk scores that I think will be forthcoming when more data is accumulated. And the drive, I suppose, one day is to be able to create risk predictions for our patients. So again, in this realm, I would say I'm not the person that is leading in this effort. There are definitely people who have been commissioned to drive our community towards that. In MOH, there is a precision medicine program led by stellar clinicians. There is, in fact, a polygenic risk score work group, which I'm trying as much as possible to pay close attention to. And there are various other components of these work groups as well, including public outreach and clinical implementation. And of course, the one step beyond the SG10K is the SG100K, which I'm also participating in, but from a very far periphery. So Singapore needs to do its own polygenic risk scores, because if you take European polygenic risk scores and apply them to different populations, you can see the predictive accuracy gets further and further down the road, down the scale. And this is clear that we need to create our own sets of risk scores, including the sort of pharmacogenetic variants that you have been discussing in all those previous talks before this. And I guess if the world is hurtling towards risk prediction, AI will come into that dimension too. So I put up two papers that is frequently showcased when people discuss about how multiple data points would be able to help you to dissect out different subgroups of patients. And if you layer on your polygenic risk score with this, you can imagine that the future really will bring precision cardiology. But I would still say that this is waiting for prime time. Perhaps it is a case where at each step of the way, there will be progressive clinical uptake in the form of beta testing. That's something that we will see coming further into the future. So for now, if you were to ask me, red flags for gene testing, inherited heart conditions is the way to go. If a patient has a relative with an early age of diagnosis, if multiple members in the family have a similar type of heart disease, if there is a family history of sudden death or unexplained death, I think this is a clear-cut set of red flags for gene testing today. So this is where I can stop. Thank you so much for inviting me to speak. I hope I've given it justice.
Thanks, Roger. We saved the best to the last, and maybe our speakers and panelists maybe want to have some comments, and then we'll try to finish in about 5 to 10 minutes time. And all of you will get your SIMI points, or rather, you will have gotten your SIMI points by now.
Maybe I can go first. I wanted to ask Roger something. Roger, what's the frequency of or prevalence rather of FH here compared to, say, the Caucasian population? Is it higher?
I wish I knew the answer, Doreen. Again, I'm not the person with the answer to that question.
I see.
I think it has been looked at. I'm quite sure it has, and someone like Yi Xiong probably has done that.
Yeah, because the numbers look a bit higher than what I've seen so far, but I could be wrong about that. And
well, if we looked at the genes themselves, they really are hidden there in the healthy, so-called healthy population that came forward for the SG10K, right? And we are seeing, 1 in 100 plus people having those mutations. Yeah, and they are pathogenic variants, so they're not just VUSs.
I'm just thinking if that's why our MI population tends to be on a younger age, right? Like our average age of MIs are like 50 something, as opposed to the Caucasian population.
Yeah, I would say that is why this is a big call to for someone to pick this up and study this properly, right? And also the TG gene variant or mutation, Doreen, that occurring in 15 individuals out of 5,000 people. That sounds like a fairly substantial number of things that would cause TG to be very, very high.
Yeah, my dad was one of them. We blamed it on his alcohol, but it could be his genes.
But more important, how do we get them tested? Do we send them to yourself or John, or how?
John, you want to take this? John's definitely a good person out there now with a genetic counseling service on offer.
Oh, yeah. So we have a collaboration with Roger. Most of it is because there isn't any formal genetic counseling service in the private sector. Rather than book and suffer a long waiting time, we provide the immediate testing. But all patients get booked and booked into the NUH and NUS cardiac genetics clinic. And usually our genetic counselor, she always consults Roger before she orders the test to select the panel of genetics. So it's done in consultation for the pre-test counseling, and then the patients are counseled and then booked into NUH. So it's a nice collaboration. We are very, very appreciative of this collaboration with Roger.
Ken Yi, I think I would just say it's really just because the Ministry of Health has such stringent rules on who can request for tests and who can't, right? So, yeah, it would be great if as soon as people get trained or so-called qualified and fit in that criteria, this can be much more democratically done.
No, and there's so many gene candidates that I can't keep track of them. And I need some people like you guys to help me.
Okay,
screen.
Yeah. If you feel so, then definitely the way would be to refer it to some central places or a few central places. Yeah.
Yeah. There used to be only like 5 or 6 hypertroph cardiomyopathy genes.
It looks like in our population, 4 genes already account for nearly 90% of the 40% that are gene positive. So
Yes.
that's actually quite good news too.
Yeah, and that's exactly why we need local data. And the more people we send to you guys, the more robust our database will be. Yeah. I think we did some familial lipid gene stuff with Tavin in Khoo Teck Puat Hospital, and we found a lot of them were LDL receptors loss of. Yeah.
Kenyi, I had an interesting question asked to me personally earlier, and this person wanted to know if the CYP2C19 intermediate metabolizers, could we double the dose or triple the dose of clopidogrel?
No data.
Edgar, would you want to take that?
Yeah, I think there's not much data, but some people have even recommended like 300 milligrams a day. But like Kenny says, these are all kind of very small series.
I think someone did that in another study and it was negative, if I'm not mistaken. I can't remember what study
Jessica
it was.
Mega, it was Timmy Elevate 56. Yeah. So
yeah,
I was going to say that actually the complete loss of function of homozygotes, no matter how you increase, is probably not going to be helpful. So this person was right in that IMs potentially could benefit from it. But I would say if you really wanted to do it, you should probably do it only if you have access to platelet reactivity testing. We had one case like that. Actually, it was a lady who had quite a lot of an HP drop on ticagrelor, was a STEMI lady. And then so she had to be admitted for GI investigations. And then so the cardiologist decided to order CYP2C19 testing, and she turned out to be a PM. So then we were stuck, right? Because she's PM and then she had a GI bleed. And then so what do we do? This was 2 weeks into the PCI that she had this so-called of a HB drop. And it was historical that she said I had flex stools. There was nothing found on scopes. So we kind of like sat there and scratched heads for a while. And then so the cardiologist said, okay, let's give 150 milligrams clopidogrel. I was like, what? But he did anyway. And then we tested platelet reactivity assay with the MEA. And she turned out to be a responder. So we left her on clopidogrel 150 for the long haul. And so it was like a repeated EMR entry that we said, okay, we tested platelet reactivity. She's fine with this. She had a query bleed with ticagrelor. So it's case on case, and I wouldn't recommend it across the board either.
Doreen, I did have a question about causality, and as the data was you were presenting the data. So, the link between those CYP variant genes and increased outcomes or increased events, right? Is that a direct link? I mean, or is it through the fact that they are not responding to the drugs?
It's more likely due to the fact that they are poorly responding because of the lack of activation. But you're right in that the positive predictive value is quite low. So if you see the absolute MACE rates, even for PMs, is about 11%. Or 12%, and that's a lot higher than what we are used to. Of course, the interventionists see the MACE rates like more than 1%, they'll be like freaked out already. But
and maybe you showed it also, Doreen. Is a good metabolizer also someone who would bleed more easily?
We couldn't find the relationship, unfortunately. Yeah, the bleeding was very messy. Because there were the data that we never.
It doesn't mean if you produce those metabolites and
yes.
You are hitting the pathway strongly that you would bleed more.
Yes, I believe it's because of the saturation of the P2Y12 receptor sites, right? Because even if you have more active drug, you still only have limited platelets anyway. So it's unlikely to cause that degree of like bleeding that we should be worried about. Yeah, and so we had unpublished data, which I never managed to publish it because of the lack of causality in literature. But we saw some signals with 2B6 actually, as in boy 2B6. There seemed to be associations with bleeding. So we couldn't substantiate that, so we never published it. I don't know whether Hedy remembers. It would have sat there for a long time, but we didn't know what to do with it, so we just left it. Yeah.
Okay, I'll need to close this. I'm sorry,
okay.
guys. I'm sorry. I need to close this. I'd like to thank. I hope all of you has been entertained. Okay, I hope all of you have been entertained. You all may have been educated, but I hope you all have been entertained. Thanks to Parkway Lab Services for organizing this. Thanks to John Chia and Curie Genetics for doing this. He was the main driver of all this, and he dragged us all on a Saturday afternoon to do this. I enjoyed myself thoroughly. I'm really sorry we ran late, but the cases were so interesting and I lost track of time completely. Thanks Roger, thanks Edgar, thanks Inghan, Xia Heng, Peter, Xuan Hong. And if you notice that Zhang Wen couldn't join us, he had a very difficult case which went on for a long time and he couldn't join us. And with that, maybe John, you want to have some last words?
No, thanks for spending the Saturday afternoon with us. And maybe we can all take a group photo if people won't mind. We can just undo the camera and then we'll snap a picture and then we'll
do we need to
we'll
do
all
this?
Yeah. How do you view the screen? Gallery view. Oh gosh.